I started in, I started in this arena in 2004. And at that time, we were already laying plans for an insurance exchange here in Oregon. That would be a standalone. We thought what we were doing, we were going that direction. And the Healthcare for All movement, our Medes project, all of those things were in play. So we were talking about healthcare reform very, very seriously. We are not in the dire straits that some people think we are. The biggest problem we face immediately here is at the national level and in the state level, we have politicized healthcare reform. Healthcare reform ought not be about Democrats versus Republicans. That's the sound bites, though, that are getting developed and we're running with, and it's causing a tarnish over the process of trying to figure out a better way to deliver healthcare. Senator Dembrow and I couldn't be farther apart on the political scale, but I think we get along pretty well. And so there are those of us who are working together on this, but the popular sort of noise out there isn't making it any easier. A couple of things that I think we did wrong as policy, and only time will tell how it will shake out, but the reform effort with the Affordable Care Act is too comprehensive. It's too much at one time for the bureaucracy and the medical profession to assimilate. I mean, the 2,000-page bill is nothing. And the bills have nothing to do with anything anyway. It's the regulations written from the bill. We're behind nationally and in Oregon in writing regulations for the various legislation. So we're not even on track to be able to roll something out and say, here it is, it's in process. And it will be in process for a long time. Building the new government computer systems to run all this has been problematic. I'm going to be kind about that. But a lot of that had to do, we have some very smart people doing it, but there was too much tinkering going on. Here in Oregon, I was concerned early on, attended a number of the Cover Oregon board meetings, and there was a constant litany of change orders going in to add additional bells and whistles when the process was rolling. If all of this rolled out like clockwork here in Oregon, we don't have enough providers to pick up the extra population and the expected expansion in usage. It's not going to be good to cover people with insurance if they can't get, they won't go in for health care. We don't have that. And in rural Oregon, particularly, we don't have it. We're losing practitioners at an alarming rate out of rural Oregon. And this thing is just a spiral of personnel problems. We have an aging population in every category of healthcare here in Oregon. We have more physicians getting very old than we have new physicians coming in. Now, a lot of those guys are telling me they're going to retire, they're going to put up with this nonsense. If they do, it's going to drive the personnel shortage even higher, faster. We're going to get a critical number really fast, starting in rural Oregon. That's where the problem is. If this works well, and it will over time, how do we provide health care to all the people we promised it to without any people doing it? And do we do it by changing practice parameters? Do we allow nurse practitioners to do brain surgery? That's an exaggeration. But, you know, how are we going to straighten out the healthcare delivery system to match people and hands and places with the patients? I'm hearing from a lot of places where we're going to use more telemedicine. Hey, that's a great idea. That ought to work out in Brothers. Let's see, we could rent a room in the back of Harry's hardware store, and we can put in a telemedicine. Oh, that's right. There's no doctor, there's no pharmacist, there's no nurse, there's no dentist, there's no oncologist, there's no nobody. Telemedicine won't work unless you have an infrastructure in place in rural Oregon to start with. That's our problem, and we have to keep the focus on it. How do we provide all of the care if the system works well? And I think it will work well over time. We're in a policy situation. we're doing policy and handing it off to doctors to say, see if you can make this work with patients. And although that's very difficult, trust me, you do not want government bureaucrats designing healthcare programs and telling you how to practice. That would be much worse. So, but bear in mind that right now, several of the CCOs that I work closely with, not all of them, really haven't done anything about cost control yet. They're still moving money around, trying to figure out if they got enough money to operate on. So it's become a money game, not a better healthcare game. It's just very premature. We just finished an interim study committee on patient engagement, and the sort of rule of thumb that came out of dozens and dozens of studies was that we have limited options on what we can do on patient engagement. The 2x4 isn't legal. And then you have to get into getting them to perform. And the question is, are we going to get results? I've asked the question, I haven't got the answer yet. But somebody has the data on how much we're losing as PEP members. And then the question is, how long can we maintain that? But it's a step in the right direction that might pay off. But we're in the infancy on all of this stuff. We can't even get electronic medical records that work really well. Some do, some don't. We don't have a universal medical record process yet. Some of those things are long overdue. So we'll get there, but there's going to have to be a lot more patience on some